Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is SeamlessMD's CEO, Dr. Joshua Liu. Today we're joined by our very special guest, Dr. Mark Weisman. Dr. Weisman is Chief Information Officer and Chief Medical Information Officer for Tidal Health. He's a senior healthcare IT executive and practicing physician with over 2 decades of experience driving growth and profitability. He also contributes widely to healthcare media, is an AMIA informatics course instructor, and is a member of the Class Emerging Solutions Advisory Board. Dr. Weisman, Mark, welcome to the show.
Hey, thanks for having me on. Appreciate it.
Absolutely. It's such an honor to have you on our show today. You've led such a fantastic career with so many achievements in healthcare IT, really across the provider and patient landscape. To start the conversation, though, I wanted to kind of dig back into your roots in clinical care world. What got you into internal medicine in the first place?
My pathway into internal medicine was that it was the shortest program after medical school. I'm like 3 years and I'm out. Yes, I want to start to live my life. Now, I did enjoy primary care. I enjoy the longitudinal piece, but I'm looking at these neurosurgeons and cardiothoracics. I'm like, they're crazy. No, I really shouldn't say that that was my main focus, but I enjoyed. One of the things I found in medical school is that I have absolutely no skills with my hands when it comes to any kind of surgical and procedural thing. So up here, I'm okay. Fingertips, not so much.
At some point, though, your hands did work on the keyboard and you got into informatics. What was the story behind that?
I remember during my residency program, I ran into this Health Information Technology magazine, and there was this guy on there by the name of Bert Reese out of Centera, and I knew I was heading towards the Virginia Beach area for my first career, and I was reading up on this guy, and I was like, man, he plays with some fun toys. He has good things, and I got to meet Bert and know Bert a little bit, and just over the years, I got involved with technology. I got involved with leadership first, and over the years, as we we're moving towards the electronic medical record years, 2007, 2008. Well, they tapped on the leader saying, hey, we want you guys in this project. I'm like, all right, this sounds like fun. And so as I always first started touching the electronic medical record, was being an early adopter and a user. And over time, I got more into analytics. That was really my pathway more than informatics. I enjoyed the data. I enjoyed learning about how the system works, where the data is stored, how to get it out. And the one who has the data wins all the arguments. I like to win the arguments, so I had to have the data. So I started noticing in the data how much our other doctors and nurse practitioners and physician assistants were struggling closing their notes at the end of the day. That was one of the reports I first ran, it's got to be 10 years ago now. And I started to get concerned about that and switch some of my focus to how do I help make life better for clinicians?
Can I ask you a totally off-script question? So you've lived through like the entire cycle. So you've had to actually work with data when it was messier, when it was like far more unstructured. And so you have a much better understanding of how data works from the ground up than someone coming into the space today. Let's say a new clinician is starting to get into informatics and IT. And now we're at a time where they have conversational AI interfaces where they can just type a query and data can, show up through conversational AI. Do you worry that the new generation is going to miss out on learning a lot of the foundational things that you had to go through to have a really complete understanding of data?
They can stand on our shoulders. I have no problems with them standing. Now, the data certainly was messy. It's still messy. We're not there yet. So I still think there's plenty of pain for those who want to experience the pain of data. And there's certain areas where we've gotten better. We've asked the questions enough times. We validated the data. We understand, hey, if we want to see this particular output, well, we got to make sure it gets in the right way. That's the informatics side. And that has matured quite a bit. So it is certainly better than it used to be. But as you start to play with some of the AI models and you're looking at what answers you get from the AI, it's like, what did we feed this thing to get that answer? And so there's still plenty of room for improvement in our data quality.
Today's episode is brought to you by SeamlessMD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what SeamlessMD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. SeamlessMD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50 plus out-of-the-box care plans available today on SeamlessMD. Go to www.seamless.md. That's www.seamless.md to learn more. Mark, I was curious, over the last couple of years, the focus has obviously shifted with health systems to tackling workforce shortages and increasing revenues to get out of the red. I'm curious how you prioritize using digital health to improve patient outcomes, which could be at odds with some of the other initiatives that you're taking to alleviate some of that workforce shortage and increase revenues. How do you balance those priorities?
Best answer there is if we can find where we help both, where, hey, we do something that has a return on investment as well as the patients love it and makes things easier for the clinic staff or the hospital staff. So an example of that is just online scheduling as an example. So our current online scheduling is pretty low. We're making this a high priority initiative for us over the next 18 months because patients like scheduling online themselves. Our no-show rate should drop because they're scheduling the appointment. They should want to come to it then. And they can cancel and reschedule. And that's less work on our staff doing it. So I'm not saying we're getting rid of staff, but our staff can do other things that might have a higher return on investment. And there's not a lot of cost to allowing patients to schedule online. Now, it takes a lot of work because you got to get the scheduled template set up correctly so that the providers aren't fighting the initiative. But if you can put the rules in place, okay, on Tuesday, I only see patients with blue thumbs and when it's full moon. If you can put that in the logic, then the doctors will be happy, the patients will be happy, and the CFO is happy too, because it all eventually adds value to what we provide. It's not always possible to do that, but where we can, we do try to align that. Those are the slam dunks. Those are the ones that we can get done. And there's a lot of energy that gets put behind it because everyone's winning there. Yeah. They're the more difficult ones, like virtual nursing. We're not sure what the return on investment is on that. I think it's soft, but I think it's there. I think, okay, maybe nurses burn out less, or maybe nursing can just be more efficient and spend more time with the patients if a virtual nurse is handling the discharge medication education. So I believe in it. I'm putting resources into it. I think the ROI will be there, but I'm not sure. But I'm not having a lot of resistance on this one from the CFO. I'm finding that, I'm swimming upstream. There seems to be executive support for let's help the clinicians feel better at the bedside. So I think that the answer is to find things that are strategic in nature and have support. When I have tried to fight the system, when I have tried to say, I want this initiative because I think this is the greatest thing, and others didn't really see that, yeah, I hit brick walls. Absolutely. About my battle scars and wounds, my scoreboard of ones that I didn't get successfully off the ground. So
On that note, so now like you wear this really unique dual CIO and CMIO hat. So, you have, let's say, a lot more influence than you did 10, 20 years ago in the healthcare system. But I'm guessing if you're trying to bring on an initiative that not everyone's on board with right away, you still have to do a lot of selling yourself, a lot of evangelizing of a new initiative. Is it still worth your time to do that? Or to your point just now, do you tend to focus on strategic initiatives that the buy-in's already there because it's not worth the effort of trying to convince everyone to do something? Let's just focus on the low-hanging fruit that everyone's on board with. I wonder, like, how much selling do you still want to do at this point in your career?
There's plenty of tech debt where we can get rid of some things that are old and need to be replaced, and everyone will be happy when we do it. But there are also those who glom onto the past, and the pager is the one that is currently in my crosshairs. So I am going after pagers. I'm trying to get rid of pagers for clinical purposes. We are using a very old technology. We're an Epic shop, so we want to move to Epic paging, and it's built into the secure chat platform. And there's resistance to this. There's a lot of selling that I'm having to do. There certainly are the early adopters who are already picked it up and are running with it. There's going to be the traditional curve of those who are going to adopt it next, and they won't give me a hard time. And I've got some who I'm going to have to pry the pager out of their cold, dead hands. They do not want to give up their pager. It's just not how modern healthcare organizations are communicating with each other. And you can't help care for that patient in real time when you're sending out a page. It's like yelling out the window. You hope someone heard it. It's one-way communication. We have to get to two-way communication, and it has to be where the clinicians get comfortable. I think they'll get there once they try it, but they're not there today, and they're fighting me on just the concept of it. We haven't even launched it, and they're fighting it. So more to come. I'll let you know how that one turns out in another couple of months, but we're trying to modernize our technology so that providers who are just coming out are like, why are we still using pagers? Like, what? Pagers? They want this more modern text messaging type feel.
Can I ask you, like, what have been some of the best ways you found over the years to convince those skeptical clinicians, the laggards in the adoption cycle? What's worked best for you?
By the way, when I see the voodoo dolls in the hallway that look like me with the needle through the eye, I'm not sure I'm always successful. Just saying that this is tough. So one of the things, at least as it relates to change management, that I've learned is the books don't apply to healthcare. The books on change management work great probably in Fortune 500 companies where you've got a nicely defined hierarchy and you need to go get that buy-in. So you go up the chain and you get the buy-in, you get cross-departmental buy-in. What they don't account for in healthcare, doctors and nurses who can have tremendous political power and they don't show up on your work chart really as stakeholders. They could be some private doctor who's out in the clinic who you aren't thinking about, like comes out of the woodwork on launch day when we launch a new EHR and they're walking in going, what do you mean our EHR changed today? And we've been talking about it for 2 years, and they're completely flabbergasted and vocal and angry. And I have found that having a soft touch and doing the hand holding and trying to get them, just working with them, if you spend time with people and show them it's okay, you tend to be all right. And yet there are some who just won't make it. There are some who say, look, I'm out. It's unfortunate. I don't want technology to be something that forces somebody out. That means we didn't deploy the technology very well. And I am seeing we're using Dragon, Ambient, Express, that technology of being able to just speak to your patient, not have to be head down in the keyboard and typing, bringing cool tools to the table that providers love. Yeah, that's an easy sell. I don't have to sell that one, but so much.
Yeah.
The harder ones are when I'm trying to force a change on them that I know is the right thing. They're not quite there yet. And I'm asking them to trust me. And hopefully I built up enough goodwill, and hopefully having the MD degree saying, look, I've practiced, I've been in the exam room. I understand the pain you go through in these scenarios. I understand what it's like to be on call. I've had a pager since I'm 22 years old. I get it. Now, how do we get you to where you can see the benefits of the technology? And they don't always agree. I don't always win. That's the answer.
I love that super oddly specific anecdote. There's definitely somebody in the organization that relates to that story really well. So I've heard you say in the past, Mark, and I think it was kind of in jest, kind of funny, but I think also true that you're a CMIO with a budget. And I think that it's such a wonderful line to highlight the benefit of a CMIO/CIO hybrid leader. Your main philosophy in that interview was around the CMIO was to make life easier for your clinicians. And I'm curious, how has that philosophy evolved over time? I'm talking like pre-2020 to then 2020 to 2023. And then what's it like today?
Pre-2020, I'm a CMIO. I'm not a CIO. And I can influence things through a lot of cheerleading, but I can't necessarily affect it. I can suggest it, and sometimes it made it, and more often than not, it didn't. And I found that being both the CIO and the CMIO, I'm doing the same thing, really, but I have to still get analysts to believe in what we're doing, and I still have to get providers to believe in what we're doing. I feel like I'm a little bit closer to being to the action now. I understand healthcare. I understand the business of healthcare. That's what I think has made me an effective CIO, is that I understand the business. And I've been in the exam room. I understand what the patients want. So I'm trying to bring that technology, the patient-focused technology. I get it. I know what they need. I understand how they communicate with doctors. They communicate with me. They've had my own personal cell phone number for years. And so I get what kind of access they want. How do I help deliver that, yet make it so the doctor can also get some sleep at night and not have the quality of life that I had during parts of the high points of my career where I was really getting run ragged by patient access. So it's fun. I can do that now when I have both roles as the CIO and the CMIO. It's not a magic wand by any means. I think what has also changed over time is that I've been in the system now 5-6 years, and people realize I'm not going to bite. I do screw up. I have my mistakes. They'll call me out on it, and I'll go, yep, you got me. I did it wrong. And that happens. And I've gotten better about, it's not, oh, I'm the doctor, I'm right. No, I'm not. I'm wrong. I absolutely get it wrong. Check your ego at the door, because you're going to get it wrong in these roles. But hopefully I can at least bring that. This is why I think we need to do this. The why. The clinical why, the business case why. I think I'm more well-rounded than I've ever been in my career in being able to deliver these solutions, because I understand so many different parts of healthcare now.
I'm also curious, advice to other CMIOs that maybe don't have that business case background or the cybersecurity and cloud infrastructure background that you also know now being a CIO as well. What advice would you have to somebody who's maybe on the fence and wondering if that's an area that they should explore and learn more, if they are really coming from that traditional CMIO background?
I really encourage people to go that route of the CIO/CMIO, having, whether you do both roles like I do, which may be insane, it's a lot of work, or just going into the CIO role and having a great right hand as your CMIO and being a partner. It can work lots of different ways. Saying it can work with the CNIO, but the biggest part is to know the business. That's the hardest part. Knowing the tech isn't that hard. Do I know how to set up the architecture for a Cisco switch in the data center? No, absolutely not. And I don't need to. And I don't want to. I want to know what the business is trying to achieve and what technology I can bring, what people I can plug into the problem, what resources do we need to be successful. That's what I can do better now than I've ever been able to do in my career. It's really understanding the business side of medicine. So our health system is working with some local urgent care centers. I helped run some urgent cares for a while in my career. I understand the business of urgent care and how occupational medicine just isn't making money for most operators in the space anymore. So, hey, I can kind of just steer them saying, let's not spend a ton of money in the tech part around occupational medicine. Let's really focus on that patient engagement, patient access. That's what's really going to drive the business. And I have the experience to speak from it. And so I would just encourage my colleagues to focus on the business, understand it. Getting my MBA was phenomenal, but also not I think a requirement. It is to be a CIO. You need to have that business sense. But I also ran my own business. I was an entrepreneur, and I learned more from that. At the same time, I was doing my MBA. That combination of running a business is what you need to know how to do to be an effective leader of an organization.
It sounds like one of the lessons from your experience has been thinking yourself as kind of a business owner, even in the context of a health system, and thinking about, well, what's best for the overall organization's goals and roadmap, like irrespective if technology is involved. Because I'm guessing from what you're describing that if the best solution for a problem in the health system is non-technology related, you'll stand up and tell people that. So yeah, I'm the CIO. You think I'm just the tech person, but actually I look at this from the lens of what's best for the whole organization, what's best for the business. And if it's tech, great. If it's not tech, that's great too.
It is an interesting dichotomy of when do I bring non-tech solutions to the table? There have been times where it has not been successful. There are times where the tech really does add value, and there's times where the tech just hasn't helped as much as I thought it would. There are solutions that I brought where it should have worked, but it just didn't. And one of them has to do with scanning. People scan things into the wrong parts of the chart. It happens. It happens in every health system across the country. People may not know that. That's an evil secret of medicine, that human beings are trying to label documents and get them to go into the chart in the right space. But the computer can read the document now. We have computer vision. It can tell you, this is who the document's from, this is what it's for, and let's just go ahead and have the artificial intelligence tee it up, and it can get filed in there. We launched that, and our people couldn't figure out how to make that artificial intelligence work well. It turned out it was better to go back to manual processes for us. I think it's the wrong move over the long term, but in the short term, we absolutely needed to just step back and reassess and find the right time. The timing was wrong on that initiative. And I think there's different leaders in place now who understand that when a MyChart patient gets a result and it's not theirs, it damages, number one, you've exposed someone else's health information to the wrong person. That's bad. Number two, someone else, another provider, could be acting on that information. That's bad. But you've also damaged the confidence that patients have in your health system. It happens all over the United States.
Right.
And it's not specific to MyChart. It happens to every electronic health record. This is a manual process that goes wrong. We've got to fix this as a health industry, and we need the computer to help do it. But in the meantime, you got humans doing it, and a lot of them do it.
It reminds me, I think, like when we talk about the opportunities for AI in healthcare, I think one of the most common things we've heard is that, folks like yourself are a lot more comfortable testing AI in some of the back-end administrative workflows that aren't going to, harm or impact the patient directly, but anything that touches direct patient clinical care, well, you're going to be a lot more conservative in how you roll something like that out. I'm curious if that's been similar to how you're thinking about it. And right now, what are the AI use cases that you think are lowest hanging, highest ROI for you right now? And what are some of the things that you're like, we got to push that further away in the roadmap because of safety or risk or other reasons?
It's a great question. The low hanging fruit is with the manual processes that it takes to run healthcare. And so I'll give an example. In the state of Maryland, we have to submit data to a trauma registry. And it's this incredibly manual process. And it happens in other states as well. Everyone has to submit data to something, some registry somewhere, cardiac registry, stroke registry, whatever it is. There's humans manually typing in blood pressures and GCS scores and medication, whatever the registry requires. It's being done incredibly manually. Artificial intelligence can do a lot of that work. If we give it the chance, it can do demographics really well. It knows the patient's zip code and can put it in the right field, really, really high percentage. When it comes to when did the doctor arrive at the bedside for whatever the incident, it's a STEMI or a stroke, when did the doctor get there? It's not so good at that because we as humans don't enter that discrete data in some place where the computer can find it. And so a human might go, I see when the doctor did their note. I know that they had a phone call first, and I could see they were looking at the fax images first. So yeah, they're probably in the building around this time. It feels about this, and we come up with the best guess. Computer can't do that. So It's never going to be where the computer completely takes over, but the computer can help these people doing manual abstraction by getting rid of the low-hanging, easy stuff. Let the humans focus on the really complex stuff. When the urine drug screen is positive, but the patient had a prescription from a doctor for a broken arm 3 days ago, okay, sure, your drug screen is going to be positive. The computer won't understand that. Human will. And the computer might be able to tee it up saying, hey, I see a prescription. Is this right? And it can make it easier for the human. That's where we have so much opportunity right now. Where it's higher risk is when you start getting into artificial intelligence helping in the clinical area. Where I think it's easy, though, is in the Dragon Ambient Express, to use a brand name, but any of the ambient technologies, listening in on the conversation and generating a note, I think is pretty low risk. But it's going to move into generating orders next, right? We know that's coming. It's probably 6 months to a year out, I'm guessing. All right, now it's teeing up. It's not signing the orders, but it's going to tee it up. That does make us a one step closer to hitting enter, and it goes into the system. And it was, if the computer heard it wrong or generated something wrong, that could be very concerning. The part that worries me the most is actually around the generative AI. There was an article published in JAMA recently. I love generative AI. I use Copilot and I use ChatGPT, and I think they're wonderful. I think they're great for writing your system mission statement. But when it comes to actually rating your discharge summary, they showed in JAMA, they asked the computer to summarize this case. All right, what happened to this patient? And then they waited 6 hours and asked again. And it got very different answers. The first answer was very generic. Yeah, the patient was admitted. They stayed a couple of days. They went home. And the other one was, oh no, they were in for pneumonia. They got ceftriaxone and azithromycin, and it was a 3-day course. And there's a lot more richness to it. Same model, same discharge summary. It just gave different answers because the AI looks at a different subset and it uses probabilities to say, here's what I think is the next best words to use. And it can generate very different results. I'm nervous about a clinician taking action based on a summary that may not be as rich as what the clinician really would have found if they dug in on their own and went deep. Now, think about the time that was saved. It was, awesome that it boiled down this 2-page summary down to 3 sentences. That's phenomenal. I think we have to continue to train the AI before I'm going to feel comfortable enough with it doing summaries of charts where you don't have to look at any of the old information. You can just go, no, I trust the AI. It got it right. I can take the summary and go to work. I'm not there yet. Maybe some others are. I'm not quite there yet.
I think one of the other things we've underestimated is how much time will actually be saved by using generative in the clinical workflow. So for example, in that discharge summary use case, I can imagine even if it generated a discharge summary, as a clinician, you feel responsible for looking back and saying, hey, did it actually pull in the right information about the antibiotics you use or the lab results? Because if you don't, you're kind of assuming it's putting in the right data. But if it's not, then that could be harmful down the road. I think the other example I think of is there's that study from, I think, Stanford recently about using generative for patient portal messages with MyChart. And the data showed it improved clinician well-being because I guess enough clinicians were using the draft note generative feature, but it wasn't actually saving time. And I'm guessing it's because actually they were, reviewing the draft note and like changing it and thinking about it. So they were less stressed, which is definitely good, I guess, from a well-being point of view, but it hasn't actually saved time so far. And maybe that's okay. Is time that important of a metric when you put your CMIO hat on with these new tools?
Yes. Time is huge for providers. They're always on the clock. Maybe when we move more towards value-based care and you can slow down and you're not on that widget wheel, I got to produce so many patients per hour, that time becomes less of a factor. But time is huge, particularly when it's not compensated time. The providers really feel a lot of stress to get that work off the table. It's interesting though, patients can tell when it's the AI writing because it's very wordy, and doctors aren't that wordy usually in their response. They're like, labs look good. And when the generative AI writes this 2-paragraph thing talking about all the lab values, the patient like, this isn't my doctor. Who the heck wrote this thing? So they can tell. But your point is really spot on, particularly when you say doing the discharge summaries. What if the doctor, when they dictated the discharge summary, only put in the most pertinent points, and it was only a paragraph instead of 2 pages of fluff, and we got back to just delivering to each other what was important? I wouldn't need the AI to do it. I need AI to fix the other doctor being just someone who's using smart links and pulling in all this junk that I don't really need. I need AI to fix that problem? No, I need the doctors to clean up the notes. That's a bigger problem.
I guess part of the thinking might be if you use the AI and you control, all the prompt engineering and you can influence the model, maybe then you can actually improve and get rid of the junk at scale. I guess that's the big hope, even though you're right, actually probably improving the training and the culture would be the best thing to do in terms of documentation, but it sounds very hard to do that, I guess, when you're working with people.
Start easy though. One of my successes for the year, on a daily progress note in the hospital, we got rid of the medication list being in there. Okay, the end user, they're in Epic. If they want to see the med list, go click on the medication administration record and look at it. You don't need it in every doctor's note. It doesn't add value. It doesn't help billing. It doesn't add anything to the case. It doesn't help someone understand what's going on. And those notes, typically your daily progress note, it's not going outside of the system usually. It's being used internally. The next doctor who comes along behind. I get it for the admission history and physical. I get it for the discharge summary, but a daily progress note, I went after that. And my team also went after, I've got an awesome associate CMIO. She really has been hammering on this, getting all the daily labs, the daily x-rays, the echo report with every measurement in it. Really? I need that in a note from the cardiologist? No. So you can get rid of the junk, and we get rid of thousands of characters in these notes, and it adds up. And my hope is that my colleagues feel better when they're reading another note, that the cognitive burden is less. They can go right to what's important and see, this is what I needed to know today, and I can go and move on to other things. That's where I want to get to. I'm not quite there yet, but we've taken a chunk out of it, and it's really helped. So I encourage my colleagues, my other CMIOs and CIOs, do that initiative. It's really easy. Get the easy stuff out of those notes, and the daily progress notes want to hit off easily.
Can I ask you, so when you're pitching that sort of solution internally, I'm sure the clinicians may get on board, but let's say you need to get sponsorship from the executive team for a solution that improves well-being, but may not improve patient volumes or revenue or finances directly. You theorize that if you improve clinician well-being, that may improve retention and reduce attrition of staff, but it's hard to kind of conclusively determine that. You know what I mean? So I'm curious, is improving well-being just an easy sale in today's environment? Or if not, how do you get executives on board with something where it's very hard to kind of just show the data in some ways that it's working?
So when we revived our notes committee, and notes committees in most places, they get really busy, they go down, they get really busy again. When we did our regeneration of our notes committee, I didn't bring in the leader from our HIM department at first. I need to get the docs settled and on board. Brought the HIM leader for the second meeting when the docs were kind of, okay, I get the purpose of this. It's not a coding initiative. It's really about doctors communicating with doctors through the chart. So our health information management team, they're of course nervous when doctors are getting together and talking about what the chart should look like. But then when they got to sit in on the meetings and heard, we're not trying to destroy the medical record. We're trying to make communication through the medical record better. Yeah, they want that too. There was no fighting, but there's no hesitation. Sure, they keep billing in mind, and they want present on admission things to be in there. So do we. No hesitation on that. So we find these things where there's just universal yes. Shorter notes with action at the top of the note saying, this is what I'm doing today, and this is what's important, and everything else that can be on the bottom. No one fights that.
You know what strikes me and excites me, Mark, talking to you about all these things, like these use cases with improved progress notes and whatnot. You sound like a chief product officer of IT for a health system, like the way you speak about it. And I wonder, do you think about your role in that way, sort of?
I still see my role as being that the person who makes healthcare better at the bedside. And That does mean bringing the products to bear, or sometimes it's just fixing workflows and making the product better. My greatest day is when the technology is completely in the background and the doctor is looking at the patient, not a keyboard, and they're having a conversation, and they walk out and their orders are done, their notes are done, and they're off to the next patient. I don't have to sell that product. I don't have to evangelize it. That's what people want. It's what the patients want. It's what the doctors want. It's what the nurses want. Nurses are going to want this technology when they're doing their head-to-toe assessment. They don't want to be clicking away in flow chart rows and stuff. They just want it to pop in there and they can move on and do nursing stuff that they want to do. So am I delivering the product? Am I trying to sell a product? I'm trying to make the product better for those who have to use it. And really, I want it to disappear. I want the product to just happen.
Yeah. I love it. So, Mark, one of the major EHR-related initiatives that you led was called Home for Dinner, and that achieved a 98% provider satisfaction rate. It's a two-part question. One, what was that initiative? And two, how the heck did you get 98% provider satisfaction rate?
But by picking the right providers is part of the answer. So this was before we had any data really around where providers were struggling. We were floundering in the dark. So Epic has what's called the signal report. It helps tell you that, yeah, your doctors are writing really long notes or they're spending a lot of time in basket. We didn't have any of that back then. So what we were trying to do is design a program where we would go into a clinic, identify where we saw the friction and say, all right, how can we make this better? And the thing we saw most often was in-basket ping pong, where the medical assistant sends it to the doctor saying, Mrs. Smith has a cold. Doctor writes back, well, have they tried anything yet? And it goes back then to the medical assistant who calls the patient, says, have you tried anything? Have they tried Tylenol? And it would be 6 to 10 messages back and forth, just inefficient. It's like, can you just stand next to each other for 30 seconds and have a conversation and fix this? Yeah. And so it was doing things like that made the providers so much more effective in the way they ran their practice. Some of them, we were unsuccessful because they were control freaks. They just they had to touch everything at all times. That's the 2%. The 98% who were happy were able to say, all right, I trust my medical assistant to take care of this for me. I can practice at my top of license. And we just helped set them up to do that. That's all we did. And then we gave them some tips and tricks about Epic and how to make me more efficient. And today I would have done the program totally different. I would put in the Ambient technology and doctors get back the joy of medicine. It just feels better. They are saving time. The initial data that we have says this stuff does work. The patients enjoy it. The providers enjoy it. The satisfaction is higher because you're communicating again, face to face, not keyboard. There's none of this where you're seeing the back shoulder of your provider. You get to see them and talk to them. So I would do it very differently today. And that's the kind of technology I can bring, where as a CMIO and a CIO, I identify that's a good thing. We're going to do a pilot. It's coming out of my budget because I think it's important. And when I told it to the executive team, they're a little skeptical, like, yeah, this AI thing. But once they've seen it used a couple of times, like, oh, yeah, that's easy. This was a no-brainer. So we're seeing the adoption kick up on this. It's not for every doctor. Not every doctor likes their notes in the format that the AI generates it in. Okay, it's not for you. If you have to have these words in bold and that's annoying for you that the computer doesn't do that, it won't work for you. But those who can give up and relax a little to say, yeah, I'll let the computer generate my note, we can really have a big impact with them with new technologies that have been developed, probably better than what we ever dreamed of doing when we did Home for Dinner. I don't know, it was 8-10 years ago now. Very, very different program than what we would do today.
I have a couple of follow-up questions on your Ambient experience and how you think about it going forward. So there was a paper that came out from the Kaiser Permanente group about their experience with AI scribes last summer, and they found, and I know this is probably outdated data now, but at the time they found that I think after 6 weeks or so, the adoption by clinicians plateaued at about 38% were actively using the Ambient. And so it made me wonder, what adoption rate for clinical tools is good enough? I mean, is 30% good, or are you like, Josh, if you don't get 60% on it, it's not really worth it? How do you think about it? Because like you said before, it's not for everyone, and that's okay. But I'm guessing if 5% were using it, it's probably not worth your time to deploy either. So what is good enough when it comes to clinical utilization?
So the return on investment does play into this. Yeah, there's a cost to these tools. We want to see people using it. If you don't use it, that's fine. Let's give the license to someone who does want to use it. And they'll probably come back around. If they're towards the end of their career, maybe not. One of our questions is, do we start to give this to the medical students and residents who are training? Because this is what they're going to use in life. We have an obligation to train the next generation. This is the tool they're going to be using. So there is a return on investment for a medical student using it? Absolutely not. They need to know how to learn to write their notes, some would argue. So I don't know. We'll go back and forth on that. I would love it to be an iPhone, right? Everyone, it's just intuitive and everyone knows how to use it and they like it. Does iPhone have a really high adoption rate? I suspect it does. I don't know what the exact numbers are. My boss she's not tech savvy and is terrified, I think, of her iPhone, but she's using it. She survives. So there's going to be those who the technology, embrace it and use it to the maximum. There's those who just survive with it and those who just obviously like working more with those who want to learn and want to try it. Those are the ones who are a lot of fun to engage with. Those who are actively resisting it, there's a challenge there. I've got to understand the why for them. And if the why makes sense, I don't push because I won't get 100% adoption. On something like the Ambient experience, I'm shooting for over 50%. I really want to see that. And if it's not at 50%, there's two reasons. Number one is because the technology is not in the background enough. Whatever it is, it's a burden, it's obtrusive, or granted, it's just an iPhone sitting on a desk right now. It's pretty not obtrusive, to be honest. So I'm optimistic. But if the product it's producing the doctor doesn't like, okay, the technology's not working. We need to get the technology to get there. And what I'm finding, at least, we're working with Nuance, and I'll try not to be too branded, but they're really putting a lot of time and effort into this product. They want this one to be a home run. And I'm sure the other vendors do this as well. But they can keep coming out with upgrades and little enhancements, and it's not as verbose if you don't, it used to just, if the patient went on and on about their left thumb and you really want to talk about your diabetes, but sure enough, your note's going to have 3 pages about their left thumb injury. It's like, what? I don't want all that in my note. It's getting better. The team at Nuance is really putting the right energy into this for it to be successful. I'm sure the other vendors do too.
I might have a follow-up question because, Ambient and AI scripts did exist, before the last couple of years, but it almost feels like with OpenAI and ChatGPT and almost like just the typical consumer experiencing generative for the first time, that was almost like a black swan event for people to go, oh, like I can interact with generative. I'm sort of open-minded to it. And I'm curious if without that event, do you think we'd be talking about Ambient in this conversation today, or sometimes we just need those black swan events for healthcare to try, new technology?
Good question. I feel that the technology has advanced past a threshold now where before, when you would have a virtual scribe, it really was someone else in another country doing a lot of the manual stuff. And hours later, your note comes in, and it's just not how we work. Like, I want today's work done today. I want it done right now. At lunchtime, I want to sign the things off. Done. 5 o'clock comes around, I want to be done with my notes. Not, oh, they show up at 8 o'clock at night. Now I got to go back in and do some more work on them. It's not how we work. So I think the technology's gotten to the point now where it is real time, and it wasn't before. And that's a huge game changer. And there's no human in the loop. So the cost has come down because there's just a computer doing the work. You don't have to be paying the human to do this manual transcription. So I think the technology getting better is really the sentinel event. So I think ChatGPT and people getting used to it. A couple of months ago, we surveyed our providers saying, do you know what ChatGPT is and do you use it in your practice? Something like 3 out of 50 who answered knew what ChatGPT was and were using it. It really just not, in my mind, changed their world. And yet we took 15, 16 providers and said, we want to try you on this new technology. They're jumping on it. So again, I handpicked the people who are using it. So, the adoption's not going to be a true test of what it's like when we go big bang, but we're seeing good adoption, particularly in primary care.
Yeah, I think for me, the funny thing with ChatGPT was because like I'm more in the tech echo chamber, right? So, I probably overestimate how much a typical person like hears about and learns about tech. But the moment that my wife is not all in tech, started like using ChatGPT, I was like, okay, maybe there's something here.
No doubt. No doubt. It is a significant leap in technology. It is one of those things that, like the internet and the iPhone, it really has changed the way we do things in this world. The generative AI is in that realm. It is that significant of a change in medicine. We haven't quite seen all that it can do yet. It'll be very interesting to see when I can use it more on my own data and have it learn more about my style of practicing medicine and getting there. We're not there yet. The models are still what someone else trained it to do. When it gets to being that personal and getting down to that specific physician's practice pattern and style and being able to generate the activities that it needs to just based on knowing you, that's going to be really, really powerful.
Definitely.
Yeah. So actually, Mark, you mentioned on another podcast episode how a future state of healthcare, we could see bots interacting with bots. Do you remember what I'm talking about?
Yeah, sure.
Could you unpack that idea for us?
So today, if I want a doctor's appointment, I can say, Alexa, go find me a doctor's appointment. And some health systems, they have that capability where you can have Alexa go and do that. And maybe it's Alexa actually talking to a human and making that appointment back and forth. But what if it's Alexa talking to the chatbot that's on our website that does scheduling appointments and stuff? And what if these two bots are having a conversation? It's important for technology leaders to understand that capability because they don't need to talk in the same language. Once two bots recognize they're talking to each other, okay, you can start going to 0 and 1s. We don't need some of the inefficiencies of translating that into speech and then in translating it back. No, just talk 0s and 1s. Okay, we need an appointment. It'll be lightning fast. Here's the options. The AI picks the right one that knows I want and delivers me an appointment. I think we can do that with refills, and I think we can do that with so many parts of medicine where the bot will be able to deliver great insights, and I can ask my bot to go out and do things for me, and it'll interact with other bots to bring that information back. I think we're close. I think we're going to see more of that, and I think we also need to understand, okay, when the humans are interacting with our bots, are they getting the experience that they want? When the human's bot on their behalf is going out and interacting with another bot, are they getting the experience that they want? Two bots can't interact with each other. We've got a bad experience, and that's not going to work. The patients will go where they get the better experience. And yeah, they may not care too much about Alexa's feelings getting hurt by our bot calling their bot ugly or something, but they will care if they don't get the appointment that they're looking for.
Right. Mark, can I pitch you a dystopian future on this topic?
Sure.
Or maybe it's utopian for you. But imagine a future where you can send a Mark Weisman AI avatar to your Zoom meetings for you, so you don't have to be there, but you trained that bot to talk like you, have the same principles as you, represent you in the meeting, and then imagine they too are talking to other in that Zoom meeting.
At some point,
someone's
going to invent bot detectors that say, all right, 95% of the people on this meeting are bots. We're ending the meeting because it's not going to be productive. But would I enjoy that I could get a summary of that meeting and I don't have to be in every meeting? I would love that.
Yeah.
Now, I don't want it speaking for me necessarily, but I would love for it to be listening for me and then bring me back the three bullet points that I need to know so that I don't have to sit through a whole meeting. Sure. Could I be more efficient that way? Absolutely. Executives, I think, would love it. Do I think the executives who are sitting in front of a room of bots looking around going, I'm not going to cancel that meeting? That could have been an email, right? I mean, you're not getting the two-way conversation. What if our meetings were meaningful? And you had great conversations where I didn't have to send a bot, where I want to be there. You want me there. and it's a 10-minute meeting to cover the topic and we're done. Yeah, that's what I want. That's the meeting I want to be.
Well, you know, at some point it's going to all go back to in person, so that way people can verify that you're actually in the meeting.
Sorry.
It might. When the AI gets good enough that it can replicate my face and my voice, and I won't send an avatar, it'll look just like me, it'll sound just like me. And if it can fool people, I'm going to try that one out. Absolutely.
You can send them to all the vendor meetings.
Exactly.
Absolutely.
So last question that I had, Mark, you used to host the CMIO podcast, which featured prominent CMIOs and digital health leaders such as Eric Topol, Albert Valerian, Neo Tala, and Michael Hasselberg. And what I noticed is in a lot of your earliest episodes, you were discussing a lot of these challenges and opportunities that still exist today, like the global epidemic of physician burnout, AI and ML, ambient tech, way back in 2019. My first question is, why did you start the podcast? And then part two of the question is, how did the podcast help you connect and collaborate with some of your industry peers on a level that maybe you wouldn't have been able to otherwise?
Okay, so the answer that you're going to put out there and promote is that I wanted to give back to the CMIO community and to help bring these ideas forth. The real reason is because I wanted to speak to experts on these topics, so I didn't have a clue what the right answer was. So I wanted to, this was probably a little selfish, but I wanted to learn. And I learned so much by doing that podcast. And I love doing the podcast. And if it didn't take so much time to do it, I would love to continue doing it. The amount of time it takes to do a podcast, as you two probably know, doing this podcast, it takes a lot of time and effort to do the editing, to find the guests, to set it up, to schedule. And it got to be too much when I became both the CIO and the CMIO, and something had to give. And so I haven't done the podcast. I love being on other people's podcasts, but I had a very hard time giving it up, but I came to the realization something's got to give. And I still love talking to really great people. I do it now more at conferences maybe, and I'll get the insights from others, and particularly the smaller conferences like Chime, where you're sitting in a room of your peers and you're talking about issues together. Love that format. Sitting in large lecture halls and listening to people, okay, there's a role for that, but I really like the small venue.
Mark, just being mindful of your time, let's flip over to what we call the Fast 5 lightning round. This is 5 rapid fire questions for you. The first question we have is, what is your favorite book or book you've gifted the most?
5 Dysfunctions of a Team. Patrick Lancioni, I may have said the last name wrong, I apologize. But very popular business book around the challenges that can happen in an executive leadership team. And as I'm working with, I gifted it to my whole team, and then we read the next book, which was really around identifying talent that you want to find to join your team. And I've really enjoyed his books in terms of helping me understand where there's conflict that's healthy and where conflict has been unhealthy.
Yeah.
And when sometimes particularly in our culture, in our health system, we're conflict adverse. We don't like calling each other out, but I've had the greatest conversations when I've gone toe to toe with someone going, I don't like your idea. They come back, well, I think your idea is bad.
Yeah.
And at the end of it, we go, oh, okay, we're going to go in this direction. We're going together. Fine. I got your back. I understand your point. We're there. And certainly when the CEO says we're going in this direction, we have a great debate, and then we're saying, all right, but then we all go in that direction together. We're really effective.
Yeah.
When we're not, when we're passive aggressive, when we don't voice our opinion in the meeting, and then the things go against us and didn't go the way we want, and then we're, when it comes time to acting on it, we don't do it, and we drag our feet. And you can really get at the heart of those problems by, one, hiring people who are willing to engage in healthy conflict, and number 2, having the healthy conflict as a leadership team. Am I perfect at it? By no means. Does my team have a long way to go? Of course we do. And I love the executive team that I'm on right now, because I think my gut feelings, maybe I'm naive, but I think we're doing a really good job at that. I feel good about the leaders I'm with. I feel they have my back. Now let's see what happens when I go and take the pagers away and the doctors come at me with pitchforks, if they're going to be standing by my side, or if they're going to be like, I got your back, way back. We'll see, but I feel confident they're going to be with me. I've got a good group.
Awesome. Question 2, who is a person, either dead or alive, who you'd love to meet?
Oh boy. I'm gonna go with Douglas MacArthur. World War II, the start, things are really gloomy. How do you turn it around and lead a country towards victory? And kind of, okay, so the European theater was really the theater that's getting all the resources. So he's resource restrained and yet still has to deliver on it. I would love to just pick his brain back in 1941, early 1942. Yeah, how's life feeling? Yeah, what's going on in your head right about now? How are you going to tackle this and turn it around? He was a fascinating leader. So
No, that would be incredible. Question 3 is a bit different. Would you rather have super strength, super speed, or the ability to read people's minds?
I want to read minds. I want to understand what other people are thinking, because I have a hard time reading minds today. And it would be great to understand the truths that are out there, not the half truths. Just tell it to me like it is. Maybe that's part of the New Yorker in me coming out. It just, no filters on people's wonderful. You just know exactly where they stand.
Yeah. No, I love it. Question 4, what is something in healthcare you believe that others might find insane?
The amount of resources and money, people that are devoted to providing things that add absolutely no value to the patient. There's an army of people, some of which is in IT, some of it is filling out registries, and some of it is billing and health insurance and pharmacy benefits. And just, there's a mountain of waste that when you're sitting as a patient in that bed means absolutely nothing to you. And so when you're a patient and you're seeing these high costs, and understand that's the cost of doing business, the cost of the business we're in. And there's a lot of waste that isn't adding value to your care. People would go nuts if they saw the actual amounts.
Yeah, love it. Last question that we have. If you could travel back in time to any event or moment, what would it be and why?
I'd want to be there in mission control when the astronauts landed on the moon. The feeling, the build-up. Are they going to make it? Is it going to work? It must have been such an awesome event. It was before I was born, but not by a whole lot either. I'm getting kind of old. But I really would have loved to have experienced that and just been in that room, been part of it, been part of the team that made that happen. That was cool.
Yeah. Yeah, it would have been incredibly exciting. And I have to be honest, Mark, your energy that you brought to this podcast episode today would have been enthusiastically embraced in that environment as well. It was honestly such a fantastic hour that we've had with you. Thank you so much for joining the show today. That's a wrap for this episode of The Digital Patient, hosted by SeamlessMD. You can follow us on Twitter at SeamlessMD. And if you like the podcast and want to learn more, visit www.seamless.md. Mark, again, Dr. Weisman, thank you so much.
Thanks for having me.